All right. Yeah. Welcome, everybody. Thanks for coming out, and I'm going to get started right on time. People will probably be coming in dribs and drabs. If you didn't sign in on your way in, if you could please check your name off that you came, and or sign the sign-in list. And then what I'll do is afterwards I'll send an email out with an evaluation with the link to the video. Hopefully that'll work. And information on how you can claim CME or CB credit. People have been asking for that, so that's great. I have parking passes if you need. They're over there. You can grab one. We may have some remote sites. If we do, please mute your phones, or your computers. Our next forum is on March 14th with Elaine Langevin. She'll talk about connective tissue, stretching, inflammation, and musculoskeletal pain. So now I get to introduce Heather Finley. Heather is a psychologist, and she has spent 25 years helping clients become more resilient and tap into their own power to manage the challenges life presents. For nearly 9 years, she's been helping clients at UVM Sleep Center get better quality of sleep and more of it, which I think we can all use. She developed the well-received Sleep Well program and is Vermont's only practitioner certified in behavioral sleep medicine. So I'm excited to learn from you, Heather. Thank you for being here.
Wow, applause and I didn't even do anything. That's great. Thank you, Kara. I'm happy to be here. I'm happy to see all of you here. And as she said, I am at the Sleep Center here and work with lots of people with insomnia. That's the majority of the people that I work with for the last 9 years. And then also some other sleep disorders as well. But I would say the bulk of my work has to do with treating the insomnia and helping people get better sleep. So we're going to talk, that's going to be the main focus of today's talk. A lot of people, when they come to see me, don't necessarily want to be using the medications they're on, or they've kind of avoided that in the first place. So this is, and being integrative health, this is a real complement to the integrative non-medication route. So welcome everybody, and thank you for having me. So I'm curious, in terms of who's here today, how many of you have someone in your life who has sleep difficulties? You don't have to say if it's you or not, but someone in your life at least you know has struggled. Okay. And how many of you are treating people who have insomnia? So there's a few practitioners here. Okay. How many of you are practitioners, but you're not necessarily treating people with insomnia, but you have some others? Okay. All right. Great. And how many of you realize you're not in the right room? Okay. So I think you're all here as you want to be. So today, I'm curious, does anyone have any specific goals or expectations? If you have anything you could shout out of what motivated you to spend time at the end of your busy day to come here in this Davis Auditorium and be with us today. Anyone? Okay. From overall health, if you focus on fitness and sleep, it kind of fits into that whole perspective. Stress, weight loss. Okay, thank you. And you were going to say something? Ah. It does. Yeah, thank you. Did everyone hear that? So she's a physical therapist who has a lot of people with pain, and with sleep deprivation and pain together, it makes it difficult to make any progress. Anyone else have any expectations you care to share? Yes. Mm. Okay. Okay. So I'm not sure if everyone heard that, but new tools basically for inpatients who can then take those tools that are not necessarily medication-based and use them in their personal lives as well, in their outpatient lives. Okay, anyone else in terms of expectations? Okay. Well, hopefully what I have on slate is good. I think it's going to fill what three of you have mentioned, but let's talk about what we are going to do. We're going to talk about the interrelatedness of insomnia and chronic pain a little bit. Talk about the efficacy of cognitive behavioral therapy, which is what I specialize in, especially in my role here at the Sleep Center. And we'll talk about the top 5 strategies that don't involve medication that I use consistently with my patients, and how some of those nuances, you might know a lot about them, but we have a chance here to delve into them a little bit more and answer any more nuanced questions about them, and also just teach the basics. And then how to interweave CBT into your practice, some of these strategies into your practice if it is appropriate for you to do so. And then to think about some resources for your patients that don't involve a pill. So that's kind of on my agenda. And we're going to leave time at the end for questions as well. So I'm tasked to try to get through the information in an hour, which I think we can do, and then we'll have some time at the end for that as well. So what I'm realizing, I need to make a little adjustment or wear my glasses because I'm having trouble seeing my screen. So insomnia, with most presentations, you usually want to know a little bit about definitions. A lot of us probably know what the definition of insomnia is anyway. This cartoon, if you can see it, when you're supposed to be thinking, you're falling asleep, and when you're supposed to be sleeping, you're actually thinking. Has anyone ever experienced that? Yeah, so that's a common theme that I hear with folks. So definition includes one or more of the following. Sometimes people think insomnia, I've had patients come in and say, well, I don't have trouble getting to sleep, it's in the middle of the night, so I don't have insomnia. So some people think insomnia is only one part of the night or the other, but it really could happen at any point in the night. It could be at the beginning of the night, it could be in the middle of the night, and it could be any time in between, or even early morning awakening, or even just the experience of having not restorative sleep. And then the key factor is also that it impairs your functioning in some way. You know, so some people might be saying, well, I wake up, but there's not really any problems. Those aren't going to be the people who complain of insomnia. That's their lifestyle, that's what they're used to, and it's not causing problems. So there has to be an actual functional problem for it to be considered insomnia. And I should also say that when you have the opportunity to sleep, you're not able to. So that's a piece of it too. It's like you go down for the night, you expect to sleep, and then sleep doesn't come. And by definition, they say, well, at least 31 minutes a night, which isn't much really, at least 3 nights a week for at least 6 months is what we call chronic insomnia. Some people have worse cases than this. Some people have any variety of combination of that. The main thing that I worry about, or I ask people about, is how are they feeling during the daytime, and that's what we really want to focus on. So, this was supposed to be animated, but that's okay. So stage 1, this is a kind of a more animated version or a cartoon version of what insomnia is, and see if you can relate to that. Stage 1, you lurch into your bedroom, completely exhausted, convinced you'll fall asleep as soon as your head hits the pillow, right? But then you lie down, stage 2, and then you're 200% more alert than you were before, right? This is what a lot of my patients say. Oops, wrong direction, sorry. Sometimes animation is great. There we go. Okay, stage 3, you try out every conceivable position. Don't get comfortable. Stage 4, you throw your blankets on and off. Your body can't decide whether it's hot or cold. Either way, you'll be covered in sweat. Here's the key. Stage 5, you aren't sleeping, so you go ahead and make use of the time by dwell on all the past mistakes you've had, and then you make sure to blow them out of proportion, right? Because in the middle of the night, that's a great thing to do. Stage 6, you finally accept, okay, I'm not going to be able to sleep, and then right before the alarm goes off, it's time to wake up and go to work, right? So this is kind of life in the day of someone who has insomnia, and this is kind of a common struggle, right? Does anyone know anyone with those kinds of patterns? Possibly? Okay. So this talk is about kind of the interconnection between insomnia and pain. So we're going to go back and forth a little bit, especially in the beginning here. So chronic pain, you know, it's a very prevalent problem. Insomnia is very prevalent, pain is very prevalent. And the two together, it's not a surprise that they are actually linked. So for chronic pain, it's usually ongoing or recurrent, and it doesn't really fit what the physicians would expect. You know, either it's gone on way longer than their disease or their illness would have predicted, or perhaps it's gone on, there's no explanation for why the pain level of intensity is as strong as it is. And then it's affecting their functioning, it's affecting their well-being. So there's many different complaints that fall into the chronic pain category. This is not an exhaustive list, but it's common. Headaches, pretty common, low back pain, neck pain, even the pain from cancer or neurogenic pain, even psychogenic pain, which, you know, sometimes can be caused from stress and other kind of psychological factors. So when you put all these together, we get quite a lot of high prevalence. Oh, and of course, we've got some of the syndromes, the chronic fatigue, the endometriosis, the IBS, and the list can go on and on. How many of you, again, work with people who have pain, the physical therapist? So, okay, about half the audience, okay. So think about what happens when you've got chronic pain, or even if you've experienced pain and can kind of get into the shoes of the other person. If you've had a pain, it's like, oh my gosh. You kind of take for granted what your body can do until it can't do that thing anymore without causing pain. It's like, are you serious? And so if you think about having this chronic pain like we described, instead of being able to focus on the basic things of life, pain starts to take up a lot of that person's awareness, a lot of that person's focus. And the similar kind of process can happen with insomnia, except this focus becomes the fatigue, you know. So then what happens if you've got insomnia and pain? Does that mean 100% of your awareness is focused on the fatigue and the pain? I don't know about 100, but it's probably pretty high. I know a lot of people that I've worked with who've got both. It's basic needs, really, if you think about it. If you can't sleep, that's a basic need. And if you can't function without pain, you know, it's just signaling to your body that you're in danger, right? Because the pain signal is usually a sign that something's wrong. So how do you just focus on self-actualization and kind of living your best life when you've got these things going on? So they're pretty fundamental to a person's well-being. And so they're common bedfellows, this pain and this insomnia. And a lot of researchers have said, well, which one came first, or which one affects one more than the other? I don't know how much you're interested in this, but I'm going to go through a couple slides because I pulled out some research studies that looked at this, just because it's kind of interesting to think about. Before we do that, though, let's talk about what you see. So people with chronic pain, majority of them present with some other kind of sleep complaint as well. And then people with insomnia, about half the people also have pain. So these are really interlinked. And so like I was saying, researchers want to know, does one cause the other, or do they kind of are they kind of a chicken and the egg process? My impression has always been they're kind of a chicken and the egg, as one worsens, the other one worsens, and they just kind of feed each other. And I think that's a pretty fair assessment. And early studies supported that as well. So, and these are early, like 92 to 01, so it's not that long ago, but in the research field, this is considered earlier for this work. So we're finding that, you know, over a majority of the studies show that one affects the other and vice versa, right? So more recently, we've been looking at prospective studies where we're doing longitudinal studies more from 2005 to 2012, and here we're seeing that there's more support saying that the insomnia actually feeds the pain more so. And so here's some interesting research they did. So this is a 12-year study. I believe this was in Denmark. So this is someone who started, these are patients, not someone, these are large studies. Patients who started with infrequent headaches, but they also had insomnia, and then 12 years later, they looked at these same patients. They were more likely, if they had insomnia in the beginning, they were more likely to develop that chronic pattern of headache. Also here we've got some people, so in terms of their conclusions, insomnia worsens and exacerbates existing conditions. The next study from Norway said, Here we've got someone who doesn't have a medical condition, but they've got insomnia. Let's follow them 11 years later. They're more likely to have new incident headaches. These guys focused on headaches. There's lots of research out there on other types of conditions too, but this just kind of gives you an example. And then there's another study that looked at, in Britain, I believe, here are people with headaches, but they don't have insomnia. They've just got normal sleep. They can remit their headache. Their headaches go away within a year just naturally through the course of treatment. So that's kind of some powerful combination of studies that you look at to say, we better figure out how to deal with this sleep problem for people who have pain, right? Pain conditions. Does that make sense? Yeah. So there's a little bit more research that we looked at too, where we could say, here are people with frequent sleep problems. 10 years later, they were more likely to develop fibromyalgia, right? A chronic pain condition. People with insomnia 17 years later had this increased risk of the musculoskeletal pain involved with, arthritis or back pain, this kind of thing, joint pain. And then there's people, again, with restorative sleep who are getting better sleep, who a little over a year later, they were able to resolve their pain more effectively. So that's pretty compelling support to say, again, let's look at the role of sleep. Because a lot of people, when they're treating pain, it's kind of a given that they're just not going to sleep well, right? I think a lot of providers aren't necessarily saying, we really need to take care of that sleep. It's just kind of like, well, okay, let's focus on the pain, because a lot of providers, we all have our silo areas of specialty, right? It's like, when I treat someone with insomnia, it's like, okay, we're focusing on the insomnia. Fortunately, which we'll get into later, the type of treatment that I do can have some positive benefits for things like chronic pain and depression and anxiety as well, but that's a sneak peek at what's coming. So, let's see, what else? So in sum, if you've got insomnia, you have increased risk for new onset of chronic pain. It can worsen your prognosis of existing pain that you've got, can influence daily fluctuations of the clinical pain, and there's even a study out there that talked about kind of a lower threshold for pain when you have insomnia. And that makes sense. I mean, when you're not well rested, if that child comes up to you and is on your last nerve, you're not going to deal as well as if you had had a good night's sleep. So sleep is kind of fundamental in terms of how you cope with anything. So this is all very common sense, I think. And then, of course, getting good sleep can improve your prognosis as well for just recovering from the various insults and injuries that happen to your body throughout the course of a lifetime. So as a provider, and this is kind of especially focused on the physicians, because most people, when they have a sleep complaint, what do? They go to the doctor. Yeah, they go to their primary care doctor. And what does the primary care doctor usually do? Yes, because and we're going to talk about that right now. So, usually the patient kind of has some expectations of the physician too, Can't you just operate and fix my weight problem? I don't want to diet. I don't want to exercise. So, we as patients often look for the easiest fix too. So we contribute to this dynamic. So what tools does a physician have? And even, non-physicians, but, a lot of times as an ancillary provider, you can support instead of saying, oh yeah, you should just go see your doctor and get some medication. It's like, oh, you should try this CBT thing that I just learned about, or you should try this. It's shown to be effective as well. So you can really have some influence on how people approach getting their sleep problems addressed. So the patient comes in, and the physician has the tools available to him or her, usually medications, right? And so there was a study that showed that in Australia, about 90% of visits resulted in a prescription for sleep medication. And in the States here, so the patient tries one sleep medication, and after a while, if it was working, then after a while the effects wear off. The patient comes back to the doctor and says, okay, it's a year later, it's not working. So maybe the dose gets increased, maybe a different type of medication works, or maybe it's several months later, it's like, nope, that has terrible side effects, I want something else. And so we go through number 2, number 3, number 4, and this is where we start to see, even using off-label medications for sleep reasons, just almost out of desperation, I would say. It's like, oh, none of these hypnotics worked, let's just try this. And so we keep trying with the same kind of tool, in a method that's not even proven to be the most effective. So that's why I'm here today, is to kind of focus on what is more effective. What's the gold standard? That's where we come in with cognitive behavioral therapy. And we look at the outcomes, and when I see patients, I do tell them, I said, you know, about 75 to 80%, the good news is that 75 to 80% of people get better sleep who participate in CBT for insomnia. And I say, but the bad news is that the key word is participate, right? Because that's, again, contrary to what a lot of us expect when we want to get something fixed. We want a quick fix. So when you look at the effect sizes, we looked at some meta-analyses, and that might not sound like a lot. Say, okay, this person went through treatment and they were able to get to sleep more quickly, by 19 minutes more quickly than they used to. Doesn't sound like a lot, right? But that's pretty much cutting it in half, and it's going to what's similar for a control group. So control group, they were about 23 different from the clinical population. Does that make sense, the way I'm describing it? Okay. So then if we look at the studies for CBT, they were able to spend 26 minutes less awake, which is a little bit less than 36. So they're pretty close to the controls here. And then they increased their sleep quality by 10%. And the way we measure that, we'll talk about a little bit later, but it's called sleep efficiency. Has anyone ever heard of that? It's basically the amount of time that you're sleeping in the window of time that you were given yourself to sleep. So if you were in bed for 8 hours and you slept 4 hours, you have a 50% sleep efficiency. That's not so good. We're aiming for 90% or better. So when we say, and we measure sleep quality by sleep efficiency. So when we say we had a 10% increase, if someone went from a 70% to 80% increase, that's pretty good. And it's only 6% different from the control group of normal sleepers. So we had large effect sizes when we looked at studies of CBT for insomnia. There we go. The total sleep time actually didn't differ that much. It wasn't statistically significant. So the control group had over an hour and a half more sleep than the clinical group. So this is an area, and I've seen this in my practice too, where, you know, sometimes they don't say they're getting any more sleep, or maybe just like maybe half an hour more sleep than before. This group was about an average of 7.6 minutes, which isn't very much, right? However, if you start to include some of these pieces, the quality, the level of restoration begins to increase, even though the total sleep time doesn't necessarily increase by that much. So it's kind of an interesting piece to not look at only the hours that someone is getting of sleep. So then if you look at the options between CBT versus hypnotics, that's usually the first line that physicians go for when they prescribe sleep medications. So the hypnotics are the PAMs and the Z drugs. Have you heard of the PAMs, like the benzodiazepines? This is where we get the, maybe they should be the AMs, because the prazolam is not a PAM. But we've got the Xanax, the Klonopin, the Ativan, those are all the benzodiazepines. And then the Ambien, Lunesta, those are also considered hypnotic drugs. Not quite as addictive as the first class of drug, but still your body gets used to them. So when we look at the effect sizes, they're actually fairly similar in one meta-analysis they looked at. However, if you think about the cost-benefit analysis, you can think about with medication, that's the best time to use medication is when there's acute insomnia. You know, someone's gone through a huge stress, or they're going through a significant loss, and their sleeping is terrible. And so just to have a short-term use of medication to help you get through that hump, 2 to 4 weeks is usually ideal. And that's the idea, is to help your body remember how to sleep again in a way, and kind of get through that stressful cycle, and then you don't need them anymore. But that's not the pattern most people take. Once they're in an acute period of insomnia, but then it's like, ooh, I like that, so let's just kind of keep using it. And then with time, your body gets used to it, you develop tolerance, so then it starts not working, or you need more, or you start trying different types of medications. And then there's also the side effects. A lot of people, it's funny, a lot of people who I work with, they stop taking the medication, or they take less, and they say, I'm not as tired in the morning. Maybe there was some hangover effect from the sleep medication, and people don't realize that sometimes, because they think, I'm tired because I have insomnia and I didn't sleep well, right? So And then, of course, when you do try to stop the medication, sometimes patients have a rebound insomnia. So that kind of just feeds their idea that, see, I stopped taking the medication, I can't sleep, that's why I know I need to take the medication. And so they're trapped in this cycle. That makes sense. And so this can also just promote the status quo of continuing to do the same thing over and over, even if it's not producing the results that you want. So some challenges with CBT is it takes effort, it takes time. You know, it's not an instant fix. You know, only one time did I have a one-session, I think it was one time, I had a one-session improvement. I had this gentleman who came in and we were talking about the basic fundamental sleep hygiene practices, you know, and we were going through some ideas, and he said, oh, chocolate has caffeine in it? I said, it does. And he said, well, I'm having a chocolate bar right before bed every night. And so he stopped taking the chocolate bar at night before bed, and the next time he came in, he's like, I'm sleeping fine. So that's very rare. That usually doesn't happen. But where'd that go? So anyway, so what happens is that for most people, it takes multiple sessions of not just having one change, but several changes that require getting out of your comfort zone sometimes to do. Another challenge is that, you know, there's limited people who do this type of treatment. I mean, there's, I know, like she mentioned, I'm the only one in Vermont who's actually certified in the sleep medicine. I think there's other people who do treatment for insomnia, but in general, or in Vermont, we like therapy in Vermont, and so there's a lot of people who do have practices don't have a lot of openings, and so sometimes limited availability can be a challenge. And then, of course, some patients don't like the idea of going to a shrink. They think they're nuts or something if they have to go to see a psychologist. And so there's that automatic resistance that has to be dealt with sometimes. But the nice thing about it is that it actually has long-term effectiveness, that the improvements are sustained. It's like the difference between giving someone a fish and teaching them to fish, is the way I think about it. And then some added benefits, as I was mentioning, some of these strategies that we use can be kind of spilled over into managing anxiety, managing stress, managing pain. And so it just teaches some skills that I think have value even above and beyond treating the insomnia. So what is cognitive behavioral therapy? You know, you might have seen it described before as addressing thoughts, emotions, and behaviors, and how they're all kind of interconnected. And so CBT in general has been around for a while. It's very effective in treating anxiety as well as depression. So pain management is also an area where CBT excels. And then, of course, insomnia. So each CBT specialty might have some specifics, and we're going to get into some of the specifics of treating insomnia using CBT. But there's also some general principles that overlap with both. And this is one of those principles that we try to look at. What kind of thoughts do we need to change? What kinds of behaviors do we need to change? What kinds of emotions do we change? And how do they affect each other? So sometimes even just learning about that is enlightening and really helpful for folks. So, as you may have gathered, CBT is not the classic, you know, kind of psychoanalytic approach where someone just sits there and talks and the therapist doesn't do anything, and the person, after they're done talking, they're supposed to feel better. And in this case, the therapist actually fell asleep, which, you know, so you're not going to see this happening with CBT, right? So my approach, the way I think about CBT for insomnia, and this is what I tell people when they come to see me for the very first time, I said I have 3 elements that I focus on and that I include when we work together. First is education. I feel like the more information you have, the more you can apply that in your life, and the more you can understand the rationale behind some of these recommendations. So things we educate about, I teach them about the science of sleep, how sleep cycles work. I teach them about the circadian rhythm that's within us, the alert force, the sleep drive. I even teach them about Pavlov and his classical conditioning, because that's the underpinnings of one of the key components of CBT for insomnia. We even talk about how the stress response works and how the relaxation response can counter it, and how that can be useful in getting better sleep. So this is all part, so sometimes I talk a lot, So that's why in a group setting, when I do the Sleep Well program, I run it really like a class. So people come in expecting to get some of that education, but then there's also a chance to do some of that interaction and troubleshooting and individual question and answer as well. So then a second component is building awareness. Because before you can change anything, you have to be aware of what needs to be changed, right? So the sleep log is very helpful in changing awareness. And then sometimes people don't realize that there actually might be some thoughts that are contributing to this insomnia. Such as, if I wake up at 3 o'clock, there's no way I'm going back to sleep, right? Or I can't sleep a night without medication. Or there's something wrong with me. Everyone else in my life can sleep, but there's something wrong with me. So these are all examples of the little chatter that happens inside of a person's head. And the longer you have insomnia, the stronger those voices get because they get repeated over and over and over again. And sometimes then they escalate and intensify. So then we focus on change. You know, like I tell them, you can't expect your sleep to get better if nothing else changes. If everything stays the same, your sleep will probably stay the same too. And so it kind of preps people to say, okay, I'm going to start this program and we're going to be doing some changes. And so that's where we get into sleep hygiene. I'll talk about these 5 things, as that's kind of the bulk of what these top 5 strategies are that was in the title of today's talk. And then these pieces, stress management, and even decreasing medication reliance is built into the program as well. Making sense so far? Okay. Still with me? Okay. All right. So thinking of another barrier to CBT, you know, just like the person who comes in and says, come on, can't you operate instead of me having to diet and exercise? I get that as well. It's like, oh my gosh, I mean, I have to see you 5 to 8 times. That's usually what I tell them if it's individual. Our Sleep Well program is 6 sessions. So it's not a one-time fix. It's also not years and years of therapy either. You know, sometimes people feel like, oh, I've had insomnia for 5 decades. Is it going to take me 5 more decades to get better? But the answer is no. So this can be short-term, but it's not instant. So I think we've talked about a lot of this. You know, it does require getting out of a comfort zone. So a lot of times a word that I use is let's experiment and let's be like scientists. So let's just see what happens, you know, because a lot of times I hear, I tried that, doesn't work. You know, I don't know how many times I've heard that. You know, maybe a year ago, maybe 5 years ago, they've tried that and it doesn't work. And so my job is to kind of encourage them to say, well, this is a different time, a different context. Let's experiment and see. Let's log it, let's track it, and kind of go from there. Oh, we're on a different slide. Did I miss anything on the previous slide? I don't think so, did I? Okay. It's funny because it's one thing here and it's another thing up here, so I'm trying to figure out where we are. Oh, yes. So then the other piece, some of the recommendations can be counterintuitive, and we're going to talk about that with sleep restriction. Sometimes people, by the time they get to me, they feel like they're at the end of the rope and they're just coming because their doctor told them to, but they're really skeptical about the possibility of this even working. So there's, you know, sometimes by the time they come to me, there's a pretty dire sense of skepticism or hopelessness. But there's also a fair amount of people who feel really hopeful. It's like, oh, I didn't know this existed. You know, I just saw someone today who felt that way. It's like, I didn't know this existed. I'm so excited to have a way to work with my sleep that doesn't involve medications. And then another challenge is that sometimes we get that external locus of control. So the external locus of control is where you feel like you don't have any internal power and everything is happening to you. Or the reason that you're sleeping is because of that pill that exists outside of you, and that's the reason that you're sleeping. So we work on challenging that external locus of control. So top 5 primary components of CBT for insomnia. You probably know a lot about sleep hygiene. You know, sleep hygiene is I don't know why they call it that, but it's the list of do's and don'ts that you probably have read in a brochure or a book or a website. So anyone want to throw out some ideas of sleep hygiene that you know? No screen time a half an hour before bed. Yep, I usually say an hour, but yeah, you kind of test where your body is with that. What else?
Very dark room.
Dark room, okay. What else? Cool room, yep. What else?
Exercise earlier.
Yep. Well, exercise period, and if you are, hopefully it's not right before bedtime. So, yes.
No food for 3 hours.
Oh, no food for 3 hours. It's always interesting, you know, when people come through, there's like different time frames and sometimes I get people who come in and they have perfect sleep hygiene and they're really truthful. It's like, yes, I'm doing all these things. And sometimes you can have perfect sleep hygiene and still have sleep problems. So it's a little misleading sometimes when you get this list, and it's very compelling because it's like, I've had people say, I bought a new mattress and I got the room darkening shades and I did this and I'm meditating for an hour and, excuse me, but I'm still not able to sleep. So it's not the be-all, end-all, but it also is a very important place to start as a foundation for getting better sleep. And that's what I tell people too, because, you know, so even the people who are perfect about everything, doing everything, usually they're not totally perfect for one. Usually we can find one area that maybe they got a little slack on, and so we say, well, let's just do that one piece, you know, because we can justify reasons why that particular recommendation doesn't fit for us, like, but I like my wine at dinner, you know, so. And at the same time, there can be some flexibility and there can be some laxness so that people don't have to feel like it's so rigid that they have to follow these rules, and if they don't, they're going to be destined to terrible sleep. So I try to have people relax a little bit more about, you know, there's always exceptions to rules. There's always, you know, let's look at some of the more obvious pieces. So when I work with people, so anyway, let's go to the second one. So second component is relaxation training. Third is stimulus control. We're going to talk about all these. Fourth is sleep restriction. Fifth, cognitive restructuring. Big fancy names for things that are pretty simple in concept. Okay. So, like I said, before any changes can be made, you have to build awareness. So this is just an example of a sleep log that I created for our program and for my patients. So basically, on one part of the sleep log, in the morning, they track what happened in the past 24 hours. And they don't have to track every hour. You know, sometimes I get engineers who are very, you know, they color-coded and they have everything really focused. So, you know, we just want to have people focus on things that are related to good sleep hygiene generally. You know, so if they're on the screen time, if they're on screen, you know, in the afternoon for work, they don't have to track that. But if they're on the screen, you know, at 11 p.m., then that would be helpful for us to know so we can track what happens if you stop the screen at 10 instead of 11. So, and it's amazing what happens when you do the log is people start to see patterns on their own. People can test their own theories without having to, it's like, well, maybe I do drink, you know, 3 glasses of wine instead of 1, like I said. So maybe if I just bring it down to 1, let's see how that affects me with sleep. And the nice thing in a class setting or a group setting is that people can share their insights if they feel comfortable. It's like, yeah, when I went down from 2 glasses of wine to 1, it really made a big difference. So for the doubting Thomases out there, it just kind of helps them really think about, maybe I do want to give that one a try, you know. And then the second half of the sleep log, we look at stats. So here's that sleep efficiency that I was talking about. We look at minutes to fall asleep. We look at, you know, how much sleep they're getting within that window that they have and what's the percentage. There's a place for them to track their relaxation practice. And then also to note stress and fatigue. You know, because sometimes people start getting more sleep, but their fatigue doesn't change. And if that happens, then that tells us maybe there's something else going on with your fatigue besides just the sleep. And that's where, you know, for pain, yeah, having chronic pain can cause fatigue even if you're getting good sleep. So we can kind of look at all that information and help us figure out recommendations for them. Yeah, so with sleep hygiene, he has a theory about her insomnia, right? So one thing I mentioned before is there's usually not one magic bullet. And usually we want to go for something that feels most obvious. And so as people are describing their habits, sometimes it can be, it's like, oh, wow, well, let's try this one recommendation because it seems, you know, if you're having a coffee at 5 p.m., what happens if you don't, you know? Another one that's big, actually, that's in the next slide, sorry. Another piece with sleep hygiene is by explaining the rationale and by helping people to understand why these things are recommended. Like, for example, a consistent sleep-wake schedule is recommended for good sleep hygiene. And once they understand how the circadian rhythm works and that our bodies really respond to consistency, there's more motivation to say, oh, my body works like that, maybe I will try to be a little more consistent. I've seen people do that. It's like once they understand the rationale, it's a lot easier to get behind a recommendation. And then to sustain the experiment, like I said, to sustain this for a good, let's try this for a good week, or let's try this for a good month and see what the effect is, instead of trying it once or twice or inconsistently and saying, yeah, that didn't work, and throwing it out the window. And really emphasizing patient choice and agency so that people feel like they're choosing what they're doing and they're not just being told, and that's part of what's helpful in a CBT strategy, is that this is an ongoing relationship. When you go in and see a provider for like 15 minutes, there's usually not time for, let's figure out which choice we would rather do. It's more like do this and do this and do this, and then that's the end, right? So some of the sleep hygiene recommendations that aren't always obvious or aren't always adhered to because they're challenging to adhere to is to not look at the time in the middle of the night. That's often in some of the literature, but most of the people that I see are still checking the time. And when you have insomnia, it usually doesn't make you feel happy to look at the time in the middle of the night. And having them look at their pre-bedtime routine and thinking about all kinds of stimulants, not just the physical stimulants, but the emotional ones. How are those discussions or heated conversations with loved ones, or those suspenseful Tom Cruise movies right before bedtime, right? And then helping them understand that alcohol use actually has a stimulant effect in the middle of the night, which a lot of people think is just a depressant to kind of relax you, but it actually can cause awakenings in the middle of the night. And I realize we've got 20 more minutes, right, for the hour mark, so I'm going to pick up my pace a little bit. So relaxation training is the second component. And here we really emphasize different strokes for different folks. So I help them get introduced to various types of relaxation techniques. I give them a CD with 5 different strategies they can try. Some of them, do yoga or some moving meditations. We talk about the neurochemistry so that they understand what's actually happening within them when they do these meditations. And encourage them to actually listen to someone guide them through a technique instead of just trying to do it on their own. Because most people aren't expert meditators. I'm not one myself. But if I'm listening to someone guide me through, it's a lot easier to redirect my attention when that voice says, oh yes, and now you're focusing on your hands, right? And so I help people by providing them with some techniques that they can actually have in their bedroom using right there. And that's why my patients can't use a common excuse people have, I can't meditate because I don't have the time. I'm too busy. But my patients can't say that. Because if they're awake in the middle of the night, they've got the time. So that would be something that I really encourage them to do. So then what we talk about with meditation, melatonin gets boosted. And melatonin is the dark hormone that helps trigger that whole series of a chain reaction for our bodies to begin sleeping. We have more oxytocin, which fights the stress hormone, and if you're in pain, your stress hormone is getting triggered as well. We get increased endorphins, and endorphins are our body's natural morphine. So if you've got chronic pain, you can see how this could be beneficial as well. And it helps you to combat depression as well because it boosts your serotonin levels, which is the happy neurotransmitter. So helping them understand that, again, helps to increase motivation to give it a try and to keep it going. So then we talk about Pavlov. Is anyone familiar with Pavlov and his dogs and that whole classical conditioning? If you're not, basically this is in cartoon fashion, how it works. So basically, we work just like dogs. We can be conditioned as well, except the conditioning is with the bedroom and insomnia. So with insomnia and conditioning, we don't want that to be associated with the bedroom. So the recommendation, this is where you get the recommendation of only sleep and intimacy in the bedroom, right? And I add relaxation training because I feel like that's a pleasant and present thing to do in the bedroom. But this is a hard one. A lot of people who've done all the sleep hygiene, they haven't done the stimulus control. because, well, it's cold in the winter, right? I don't want to get up in the middle of the night and sit in my cold room doing I don't know what and not be in my comfy bed. But the idea is to really focus on, let's associate the bedroom with these things that are sleep-inducing, with things that are more promoting of sleep instead of alerting and stimulating. And then we sometimes have to modify it for someone's like, well, I don't have another room to go into. So then I narrow it down and say, let's just have the associations be with the bed. So if you're not sleeping, if you're kind of tossing and turning, you know, like that first cartoon, if you're having any of that, take that out of the bedroom so you can associate that outside of the bed. So for one-room situations, the bed is when they're sleeping, and then the chair or the floor or somewhere else, the desk, is where they go when they're not sleeping. So we talk about ways to modify it in that way. Because the main goal is to take these things out of the bedroom so we can let classical conditioning work in our favor instead of against us, right? Take the frustration out, take the restlessness out, take the tossing and turning out of the bedroom. And this is a very strong, powerful method, even though it sounds so simple, and there is some resistance. So in the bedroom, you want it to be pleasant and present, is one way to think about it. So sleep restriction. When I say that, it's a terrible name. I think they should have called it sleep consolidation. But when I say sleep restriction and introduce patients to it, I usually get the deer in the headlights look, right? Because it's like, if I spend less time in bed, what if I only sleep half of that time? Then I'm only getting 2 hours of sleep, and oh, this is going to be terrible. So there's a lot of patient resistance to this strategy, again, because it is so counterintuitive. So I help them to understand why it's effective and kind of counter their fears that their worst case scenario is going to happen. And the interesting thing is that they're often spending less time in bed, sometimes getting more sleep, but even if they don't get more sleep, they're getting more consolidated sleep, and that reduces fatigue, right? And that's incredible. So when they start having less fatigue, then it starts getting the momentum going in the other direction. Sometimes it can be a challenge to sustain, especially in the beginning for sleep restriction. But that's where, you know, when we have our ongoing meetings, I can help them look at some of their fears and look at how to modify it if need be. So if you think about what the benefits are, we've got increased sleep efficiency, which is, you know what that is now, right? So you've got increased sleep efficiency, which decreases fatigue. And as they have less fatigue, they have more confidence in their ability to sleep. So now we see the momentum going, you know, the ball rolling in the other direction. And as they feel more confident, there's decreased anxiety and dread in the bedroom. And as that happens, they start to get better sleep, and it's working well for them. And sometimes you even have the paradoxical effect where someone's saying, first, before sleep restriction, they say, I can't get to sleep until 1 o'clock in the morning. And so with sleep restriction, we say, okay, you're supposed to stay up until 12:30, and then they come back and say, I couldn't stay up until 12:30, I had to go to bed. So they had kind of the paradoxical effect of, you know, when they were told to stay up, they couldn't unless they were doing something like this. And usually, you know, the research shows that you get a positive result if you can do this on an average of 3 weeks. I've had some patients who the next week they're starting to feel like they're getting better sleep. And for others, you know, it might take longer than 3 weeks. And for others, they're like, I hate this strategy, I'm not using it. But, you know, again, we use multi-components in this treatment, and everything's not going to work for everyone in the same way. And that's where it gets kind of interesting, because everyone's sleep soup is going to be different in terms of what the different ingredients are that create better sleep for them. So in the last component, this is the real linchpin, I think, of CBT. It's cognitive restructuring, which is just a fancy way of saying we start to repattern your thought habits, right? And I would say this is probably the most difficult one to do via self-help. You know, it's hard to give someone a book and say, here, just get a different attitude about your sleep, right? But that's why in the group setting, especially, I think it helps people to have that attitude adjustment, shall we say. So in the class, what we do is we have people fill out a questionnaire. This is a fairly widely used questionnaire, dysfunctional beliefs and attitudes scale. And they rank how much they agree with these questions on a scale of 1 to 10. And so what we do is go through and ask, which items of these 31 questions did you answer 8 and above? And we go through each of those 30 questions, and anyone with an 8 or above, we look at that and say, okay, if this is high, there's a better chance that you probably have one of these distortions going on, and I ask them to figure out which type of distortion do you think this might be. Do you think it's misidentifying the cause, overemphasizing? And as we go through the different questions, and then once we figure out the distortion, then we talk about ways to challenge it. And so it's a really rich discussion. We spend almost a whole session, which is like an hour and a half. We spend almost an hour going through this questionnaire and going through how to challenge these different types. And so, person A is over here, and let's say they answered yes to 5 questions, and 4 of those is overemphasizing the impact of poor sleep. So at the beginning, if they were skeptical, thinking, but these are true, once they start seeing that, oh, well, maybe I do have a tendency to overemphasize the impact, then they start to have that awareness of their tendencies cognitively. And once you have the awareness, then you can begin to make some of those changes. And so this is really, I think, where people start to turn a corner. And it's really the glue that holds this treatment together. So I used to actually work with people who had chronic pain. That was my specialty when I first started private practice. And I worked with Dr. Magdalena Naylor in her mind-body pain management program. And so something that we talked about with chronic pain was what's most crazy-making about it is the lack of predictability and the lack of control, right? And I would say you could say the same thing with insomnia. Part of what's crazy-making about it is the lack of predictability and the lack of control. Does that make sense? And those things can feed these, the depression, the anxiety, the anger, the frustration. And so what we do to address those, the sleep log helps to predict a little bit more, helping to understand how the alert force and the sleep drive work helps to increase predictability as well, because then we're looking at how our physiology works. We're looking at science. We're looking at nature, and that becomes a little bit more predictable in terms of how our bodies work for a regular sleep cycle. And then for the lack of control, we really try to focus on more internal locus of control. I mentioned that locus of control concept earlier. So if someone is starting to get, let's say someone's medication hasn't changed, but they come in treatment and they start getting better sleep. So we can say, it's not the medication that made these improvements because that didn't change, right? But you're getting improvements and you've done all these things that are totally under your control. So then it's based on their efforts. That increases their internal sense of, oh, I can do something to affect my sleep, which addresses their sense of control, right? And then it also helps them to challenge beliefs about medications, like, well, if I can get these better results, or if I can even have less medication and sleep better, then my beliefs about the medication were kind of off base before. But it's hard to know that until you start getting some proof, because before that you've just got the fear of, oh my gosh, if I don't use this medication, then I'm going to be in big trouble because I've tried it before and I know what happened and I'm not going to do that again, right? So really, what's most recommended, because CBT, as I said, has some core components that can be used to treat the anxiety, the depression, the pain, the insomnia. However, as you've seen with these 5 components, some of them are very specific to treating insomnia. So for someone who has insomnia and chronic pain, a hybrid approach is really recommended, because you've got CBT that can address the insomnia piece, and as we know, insomnia can modulate pain and how it plays out, the prognosis. But it doesn't really specifically address all of pain management. Likewise, you can do CBT for pain management, but it's not going to get at all the sleep components. So it's a lot of work on the patient's part, but it's also a lot of work having chronic pain and insomnia. And so one option is to continue to live with those and suffer with those. And the other option is to get, ideally, some CBT for pain and some CBT for insomnia. And the nice thing is, even though it might be a lot of treatment for the person, they're both short-term and limited. And then the overlap that you have is actually going to reinforce and strengthen them. So if they learned how to challenge their tendency to do catastrophic thinking with pain management, then they can also say, oh yeah, I did that with pain, I can do that with insomnia too. Does that make sense? So in terms of resources, as you know, we've got a sleep program here at the center, and a lot of people out there think that the sleep center is just for people who have sleep apnea and narcolepsy and some of these, medical sleep disorders. So more recently, people are becoming more aware that they've got someone like me there. I'm the only psychologist on staff, and like I said, they have me there because I do the kind of treatment that's best for insomnia, and insomnia is so prevalent that it warrants my position to be there. So anyway, so that's a resource. And like I mentioned, I do individual treatment as well as whenever someone can, I try to get them into the Sleep Well program, which is a class setting because of all those extra benefits that I mentioned as we were talking. Because then you've got, you're not alone with the experience, you've got the extra motivation and accountability of going through these changes, and it's kind of a fun way to go through them too, because it can be challenging, but when you're in a group setting, you can kind of make light of it together. And then in terms of challenging those cognitive distortions, that's very powerful in a group setting as well. So I try to get people to do that. And then for pain, we've got the pain management program with Dr. Naylor here at our Mind-Body Medicine Clinic. I believe her program is a 12-week program. It used to be. Maybe it's 11, somewhere. It's over 10 weeks anyway. My program is 6. And then sometimes patients don't want to go through treatment or they're kind of more the self-help kind of people. So we use the Insomnia Answer as our textbook in our class. So this is one I often recommend, but there's also a few there's plenty of books out there, but these are a few that I'm familiar with that seem like they're pretty good resources for patients. And what I should say too, last year we started developing a telemedicine program to deliver CBT for insomnia via telemedicine. So for patients who were in the Northeast Kingdom and Montpelier area, we were able to develop that program so that, they didn't have to travel in the winter months or spend a lot of gas money to travel, over 2 hours, 1 to 2 hours one way. So that's a nice resource that we have here too, if you're aware of anyone kind of on the outskirts who might need to still get treatment but don't want to drive. And of course, there's an app for that too. So for the relaxation training, these are some popular ones. I often point people to this one just because I'm more familiar with it, and I actually demonstrate it for them, and I show how there's playlists on here. There's a playlist for sleep. There's one for stress. And they're always adding more. And I've had some patients say they really like the Calm. And when I looked up this little icon, it also says they just added these sleep stories. I don't know what those are. I just found out about it today. Do you know about them? Oh, good. Excellent. Well, hopefully they're helpful for you. Yes. So I don't know what the sleep stories is all about, but the idea is that it's going to help people, foster, get their minds and their bodies in a place that allows sleep to come more easily. Yeah, so here, I guess what I wanted to ask, we could do this, let's just do it in the large group. Is there anything from here today that you want to, that would be an easy idea for you to incorporate into your practice or maybe into your personal life that you feel like that's something I haven't tried and I think it would be easy for me to incorporate? Does anyone have anything that you think you could share that you want to let us be your witnesses to? Yes?
I'd like to know more about the sleep restriction. I wasn't clear.
Oh.
It sounds like you just, earlier you shrink the amount of time.
Okay. How about we cover that in the questions period that's going to start pretty soon? So remind me if I don't get to it. Okay. Any other easy ideas to commit to that anyone wants to share? Oh, okay. Yes.
Well, I've heard that sometimes it's difficult to get to sleep because of gastric acid.
Mm-hmm.
So taking a Tums late at night or just before you go to bed is good. Do you know anything about that?
I don't know about any research with that. I would kind of put that under the category of kind of managing a medical condition. So if there's something that is preventable that you can, if you have GERD or, the reflux and you know that this tends to get activated at night, a lot of people modify when they eat or what kinds of foods they eat. Or if it's just acting up, then taking a Tums to kind of settle that experience so it's not distracting you. It's kind of like, so it's not creating that painful experience that prevents sleep from happening. So a lot of times if it is a medical condition or a pain-related condition, if there's anything you can do to alleviate the pain, then, it certainly can't hurt.
Yeah, this source said that people are often not aware, totally unaware of it. So no pain, no nothing, but it is actually
Oh.
causing some restlessness.
Interesting. Well, I haven't heard of that then. I'm not familiar with that. It could be a good test, a theory to experiment with. Yeah. And then you were going to say something, Kara?
Yeah, I think it's just the solution cutting the addiction off a little bit earlier.
Okay. Yeah. Yeah, sometimes easy, sometimes not. You know, it's funny because I have a lot of people who say, you know, when we talk about screen time, then I've got people saying, oh, I've got an app that filters out the blue light, so no worries. But actually, I did recommend that app to a teenager tonight who, today, because, you know, she's getting home late from a job or something, and she had to do her homework, and the homework has to be done on the computer, so I don't want her not to do her homework. So there's this app, if anyone's interested in trying it. I don't necessarily encourage it, but if people are like, there's no way I have to be on my computer at this point, there's an app called f.lux, L-U-X, and I actually put it on my computer as well just to see how it works, and it basically creates like an orangish glow in your computer so that you don't have the blue lights at nighttime, and it automatically calculates when it needs to get to that orange hue. So anyway, so if someone's having challenges with that, the other piece, even if you have the f.lux or some kind of filtering app, your mind is still engaged in whatever it is you're doing, you know. So there's kind of multiple components to that recommendation too. So, yes. That's a great question. So the question is, what about these backlit e-readers like Nooks and Kindles? So yeah, the idea is that if they're backlit, they probably have the blue lights. Kindle, I know, makes some like a paperwhite that, you know, if basically you can't see it in a dark room unless you have a light on, then that would be fine. But if you're in a dark room and you can read it, then it's probably got a backlight that's going to affect you. Yeah. So, yes.
I don't know if this is appropriate for the question session, but I'm curious what you think about devices like Fitbit that supposedly can tell you, the next day how much you slept, how much you were rested. Is that accurate? Is it useful?
That's a good question too. Can I hold that till the question section? Yeah. So, because they're very popular these days. Okay, so I guess, I just wanted to close before we do more questions. Then I was just going to have you think about an easy idea for you to incorporate or to incorporate for your patients or into your practice with patients, and then a stretch idea to incorporate. So that was just kind of an invitation for you to think about what changes might you want to make as a, either person who has insomnia or working with people who do have insomnia and or chronic pain. And then to close, I just wanted to share a little bit of what we do in our class. We spend a session talking about coping with emotions, because when you have insomnia, usually you've got, some anxiety that's developed if you didn't have it already, and frustration, anger, even sadness. So we talk about, as a psychologist, I almost feel like I have to talk about how to manage emotions, because that's part of that triad that we talked about in CBT. So anyway, one of the recommendations is to have a haiku journal, and to just express using kind of a somewhat right brain activity. So right brain is creativity, and poetry fits in the right brain activity. So I have the patients create a group haiku about sleep or insomnia, and I just kind of leave it open, and they kind of, one person takes a line, and so it kind of becomes this group phenomenon. And so I've written them down over the years, and so I picked a few for you to share to close on. Can I do that? Would that be okay? Okay, so, first of all, this is an example of people doing haiku. The way haiku works is it's 5 syllables on the first line, 7 on the second line, and 5 on the third line. So people are like, how much can I fit into a haiku format? Oh no, I'm out of, right? So you have to use your creativity to come up with the actual format of haiku. So first one, daydreams of night dreams. I will sleep better at night. Pipe dreams in my mind. The clock ticks unseen. Elusive sleep comes and goes. The snow continues. Tonight I will sleep without my medications the whole damn night long. Pardon my French. And finally, close my eyes, breathe in. let go of my day's events, relax, fall asleep. So a lot of these patients, they say, I can't write poetry, but they've come up with some wonderful things, and that's why I love haiku, because anyone can do it. And so I just encourage them to say, just it takes a couple minutes just to kind of tap in and think and write down, express how you're feeling. So in closing, I just wanted to give you a few sleep-related haiku that our patients have created over the years. And I wanted to thank you all for your interest, your attention, being here. And we can move to questions. And the next slide is going to have some of the resources and references that I used for these studies that were quoted and everything else. So I think, oops, shoot, sorry, in case you're interested. Okay. All right, so thank you. So now there are questions. So there are questions about sleep restriction and questions about Fitbit and maybe more. Sorry, let me just get this up. Okay. So sleep restriction. So the way sleep restriction works is we look at what's been happening. So this is where the logs come in handy. And we look at, okay, when has the person on average gone to bed, and when on average has the person gotten out of bed. So we create their sleep window for the last week. So let's say they said, well, my window was 10 to 6, right? So an 8-hour window. But when they really looked at the numbers, they realized that they're only sleeping 6 of those 8 hours, right? So that means they were awake for 2 hours. And so what we would do is say, okay, the purest form would say, let's only have you spend 6 hours in bed. Let's shave off the time. Let's only spend that much time in bed. But what we do is the kinder, gentler version, which is to say, if you're awake for 2 hours, let's shave 1 hour off. And that's going to be the time that you spend in bed, with the idea that you have less time to spend in bed and you will get more efficient sleep during that time. And the analogy that I use in thinking about it is that of creating a pizza. So have you made a pizza at home? Can you imagine making a pizza at home? Okay. So let's say you have a small ball of dough and a big pizza pan. And you try to stretch the dough across the pizza pan. What's going to happen to it? It stretches out, and as it stretches out and it's not enough dough, what's going to happen? It breaks, right? So that's similar to someone with insomnia who's, they're trying to stretch 4 hours of sleep across an 8-hour window or something. There's a lot more breaks in the sleep. It's more fragmented. And so what sleep restriction does is say, you've only got this much dough, so instead of trying to make a big pizza, let's shrink down the pan a little bit. So we'll take that amount of dough, and that way we'll cover the pan nicely, have a nice solid crust. And then as you get that solid crust, let's say you're getting at least 90% of that 6 hours, then we say, okay, that's not enough. It's good quality, but I need more. Then we increase the pan incrementally, so by half an hour. And, after you have a week of 90% efficiency, you increase it by half an hour until you get 90% efficiency at that level. It's like, does that fill your appetite for sleep? Well, no, I still need a bigger pizza. So then we kind of gradually stair-step it up, if that makes sense. And so the way we restrict the sleep depends on the kind of insomnia you have. So if you're taking 2 hours to fall asleep, we would shave it off the beginning part of the night. So instead of going to bed at 12 or at 10 o'clock, you would be going to bed at 11 o'clock. And you wouldn't be napping during the daytime either. So what happens is they learn about the sleep drive. It's like if you're not napping and your body only has this given time to sleep and it's consistent, then your body eventually is going to fall into that rhythm and you're going to be able to sleep more of that time. And then you get that whole cascade of then they feel more confident, then they feel less fatigued, and they feel less anxious about sleeping, and so it goes. Does that explain it well for you? Oh, you're welcome. Welcome. And a Fitbit question. So you said, what's the value of that and how have people been using it?
Is it reliable?
Those Fitbits. So we have something like that that's more high-tech called an actigraph. And so basically they're activity monitors. And so the Fitbits are now, a layperson's actigraph. So actigraphs and Fitbits can have their utility. The challenge, though, is if you're a restless sleeper, then your Fitbit might be saying, I woke up 30 times last night. I don't remember that. I must be getting terrible sleep. when in fact, if you didn't have the Fitbit, you might not have that same kind of process happening. Similarly, I've had one person with an actigraph, again, which is like a Fitbit, and I looked at it and I said, you were in bed until noon? What was going on? Like, I mean, you were sleeping till noon? Because that's what the actigraph looked like. And they said, no, I wasn't sleeping till noon. What day was that? Oh, I was just in bed watching a movie. You know, so it just goes on activities, so it's a little bit misleading. But if you use it in combination with your own memory and like the log, I think that could have some value. And I've had some patients who feel reassured by the changes they see in the Fitbit. You know, so I try not to let them kind of freak out or get too worried about the number of awakenings and everything, especially if they get really, really focused on that. But then if we look at trends, then I think it can be useful for trends in that way, especially when you combine it with your sleep log results. So, does that answer that question? Okay, good. Yes?
Can patients self-refer to your program?
They can. So what they would do to self-refer is just call our office, and then our office, we have kind of like a screening process where, not a screening, but somewhat of a gateway process. So when they call, they will get sent a questionnaire. When they get the questionnaire filled out and it's returned to us, then they'll be able to schedule an appointment. So it just kind of is an extra step to make sure that it just wasn't a referral that they're not going to follow through on, because usually once they fill out the questionnaire, which is pretty extensive, they're more likely to show up, and it shows there's some motivation there. So, but yeah, they can call up and say, I'd like to see me, Dr. Finley, and then they will ask for information, they'll get into questionnaire, we'll get it back, they'll get scheduled for an intake and go from there. Yep. There was another question. Yes.
So how do you feel about power naps that were kind of a trend for a while, you know,
Mm-hmm.
in terms of actually helping with fatigue, but also are they disruptive to the night's sleep?
That's a great question, and that's where, we talk about how the sleep drive works, and so there's actually research showing that a 20 to 40 minute nap can actually boost performance mentally and physically if it's taken at the right time. So, there's a dip in alertness that happens in the early afternoon for most of us. In other cultures, it's siesta time. In our culture, people are grabbing for coffee and sugar and everything else. But that, in that early afternoon time, a 20 to 40 minute nap can be helpful, especially if you're not getting enough sleep at night. A lot of people I work with who have insomnia can't take a nap for the life of them. It's like, I'd love to nap, but I can't. And so for them, I say, well, even if you can't nap, rest and do a relaxation technique, and then that often can be even more restorative than doing a nap. So
you feel like taking that 20 to 40 minute power nap will disrupt someone's regular sleep at night?
Not if they've got a regular nighttime hour. Like if it's like a 2 o'clock nap or something, and then they're going to bed at 9 or 10 o'clock at night, it's far enough away. For most people, I can't say definitively for everyone, but in general, it shouldn't do that. So, but that's where your experimenting and testing would come in to say, how is it playing out for me? Yeah. Any other questions, comments? Yes.
I'm curious to know if you get the same results with the sort of gentle sleep restriction as you do with
That's a good question. I don't know. I just do the kinder, gentler one. Just that's what I do. So I don't have the purest to compare to. I just find that people seem to be more receptive to it when I say, well, we're not going to shave off the 3 hours. We're going to shave off an hour and a half. And it seems to be, for people who stick with it, it seems to be getting the results we're looking for. So I haven't had a need to try the other. That's a great question, though. Yeah. Yes.
Do you work with young children? So how young?
Oh boy, yes. So we used to have a pediatrician, Dr. Appleby, on our staff. And he's in Albany now, so he's not with us anymore. So now I am the pediatric insomnia go-to person. I haven't worked with a lot of kids so far. I would say, less than 2 handfuls probably. I worked with more teens, but I've had some as young as 2 or 3 years old come in. And in that case, we're not really working with the child, we're working with the family, the parents, because a lot of times there's types of insomnia for kids, that involve limit setting on the parents' part, or the kids get used to a certain thing that they need for their to go to sleep. It's called sleep onset association insomnia. So for those situations, we have to just teach the parents what that's all about and teach the parents to kind of have some new habits around that. So, but it's challenging because sometimes there's some resistance there, but we've also had some good results because you want the child's just starting out their lives. They don't need to start with insomnia at this point, and the parents are sleep deprived at that point too usually. So, if everyone could be getting better sleep, that would be good. So that was a long answer to say yes, we do work with pediatrics, and I don't know, I haven't worked with an infant yet. I'm not sure what I would do in that situation. I think probably 2 and 3 is probably when people start to have those problems. Yeah. Oh, and yes, and then the teenagers, then you've got circadian rhythm problems, right? Where there's a natural biological drive for teenagers to want to sleep later and get up later, so that's a real thing. But in my opinion, I mean, it could also be trained, so you can give in to that natural biological phenomenon that happens for adolescents, but that's just going to make matters worse, especially if they're trying to get up for school and everything else. So if they can be taught that, there's actually factors that you can do, there's things that you can do to train your system to fall asleep earlier than it wants to right now. So I talk to them about it as if they were traveling to a different time zone, and I talk about our internal clock in that same way. So it's like, so your clock is somewhere in the Atlantic right now, some island at the Atlantic. We need to get it back to Vermont, and so these are some of the ways that we can do that. Melatonin can be used. I should say, too, that melatonin is often mistakenly used as a sleep aid. So often I'm educating people to say melatonin is usually used as a clock aid. So if you think of your sleep clock, if you're pretty consistent with your schedule, then melatonin isn't going to help you get to sleep any better. If your schedule is off, like you want to go to sleep at 10, but you're not able to sleep till 1, then melatonin can be helpful to shift that clock backwards. And so that's where, for adolescents, that's where I see the use of melatonin being useful or helpful. The good point, yeah. So light therapy is also, so the schedule and light are two elements that train your clock. So yes, so having people get bright light first thing upon awakening, ideally as close to awakening as possible to get the most effect, and then again, not having a lot of light at nighttime, because our clock is based on light and schedule. So that's a good point to bring up.
Isn't it true that if you watch the sunrise, it helps you get to sleep more easily at night or night?
Well, I could see how that could make sense in that, you're getting that light to kind of trigger, this is the beginning of my circadian rhythm or my clock cycle. And so then naturally, by the time night comes, your body will say, okay, we're at the end of our cycle, now it's time to go to sleep. Yeah. Yeah, right. Any other questions, thoughts, concerns? Good. I think that's a wrap then. Thank you, everybody. Sleep well.